Assalamualaikum.
Hello, can you hear me?
Cek.
Tes. Assalamualaikum Prof. Jaliha. Can you hear me?
Yes, I can hear you very clearly.
Mas, di-show-kan Mas, ditampilkan Prof. Jaliha, terus Pak Budi Santoso. Oke, Prof.
Alright, oke. Boleh dengar?
Ya, sudah dengar jelas Prof.
Alhamdulillah.
Oke.
Assalamualaikum, Prof.
Waalaikumsalam.
Terima kasih, Prof. Bergabung di Unimus.
Alhamdulillah, sama-sama.
Dengan Vice Rector 1 Prof. Dr. Budi Santoso.
Apa kabar?
Baik, thank you very much.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. Welcome to our opening ceremony, the first international conference on practice and innovation in midwifery. This event was held in collaboration between University Kebangsaan Malaysia and Universitas Muhammadiyah Semarang, Indonesia. The Honorable Rector of Universitas Muhammadiyah Semarang, On this occasion was represented our Vice Rector 1, Dr. Budi Santoso, Magister Science Medicine, Honorable Professor Dr. Zaleha Abdullah Mahdi from University Kebangsaan Malaysia, Honorable Dean of Faculty of Nursing and Health Sciences Unimus, Dr. Ali Rosidi Magister Science, Board of Faculty members, and also our Chairman of the Midwifery Study Programs Unimus, Honorable Director International Relations Office Unimus, Dr. Muhammad Yusuf, PhD, the Honorable, our beloved speakers, and also that I respect all audiences and participants. First of all, let us pray and praise to Allah Subhanahu wa Ta'ala. Because of His blessing and mercy, we can gather in our agenda today with healthy condition. Secondly, let us greet and pray to our beloved Prophet Muhammad Sallallahu Alaihi Wasallam, who had brought us to the path of light and left the darkness in this life. Regarding to our topic today, this conference having purpose to give and share an information to health workers about emergency services, reproductive health, medical legal of emergency services, on maternal and neonatal, also women's reproductive health service in communities both in Malaysia and Indonesia. Ladies and gentlemen, let me Ulfa Isnaini as the master of ceremony delivers the structure of the event today. The first one is opening. The second one is singing national anthem of Indonesia Raya. The third one is committee chairman report. The fourth one is speech by rector. The fifth is main agenda or conference. The next one is introduction to midwifery journals, and the last one is closing. Ladies and gentlemen, let us open this agenda by saying basmalah together. Bismillahirrahmanirrahim. The second agenda is singing national anthem of Indonesia Raya. For all audiences, please stand up. Thank you. Have a seat, please. Have a seat, please. The next is the committee chairman report. Please, Mrs. Lia Mulyanti. Time is yours.
The Honorable Professor Dr. Zaliha Abdullah Mahdi from University Kebangsaan Malaysia, Honorable Vice Rector 1, Dr. Budi Santosa, Magister of Science, the Honorable Dean of Faculty Nursing and Health, University Muhammadiyah Semarang, Dr. Ali Rosidi, Magister Science, the Honorable Head of Diplomatry Midwifery Study Program, University Muhammadiyah Semarang, Mrs. Dewi Pustaningrum, Magister of Health, the Honorable Head of Institute for International Affairs and Protocol Cooperation, University Muhammadiyah Semarang, Dr. Muhammad Yusuf, PhD, and all the midwifery lectures, University Muhammadiyah Semarang, and participants that I care and are proud of. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillah. Praise and pray in the presence of Allah Subhanahu wa Ta'ala for grace and gift we can together to join even the first international conference on practice and innovation in midwifery, or ICPIM. The purpose for ICPIM is provide information to health workers about emergency services, medical legal emergency maternal neonatal services, and women reproductive health in community spot in Malaysia and Indonesia. For this agenda, we invite Prof. Dr. Zaliha Abdullah Mahdi from University Kebangsaan Malaysia as speaker. And then from Indonesia, we invite Dr. Fitriani Nordamayanti, Magister of Health Law from Diplomatry Midwifery Study Program, University Muhammadiyah Semarang, as speaker. And the last, we invite Mrs. Serkia Istiarsi Prakasiwi, Magister of Midwifery from Midwifery Professional Bachelor Program, University Muhammadiyah Semarang as speakers. Today, ICPIM event has attended by health lectures, health workers, and health students from various regions in Indonesia. With a total of 300 participants, we are grateful from the support of various parties so that event can running well. Finally, if there are words that are not pleasing for us, we apologize professionally. Congratulations on joining ICPIM. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you. The fourth agenda speech will be delivered by our Vice Rector 1, Dr. Budi Santoso, Magister Science Medicine. Please, time is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Respectable Professor Dr. Abdullah Mahdi, Professor of Obstetric and Gynecology, University Kebangsaan Malaysia, Dr. Fitriani Nurdamayanti, Lecturer of Diploma 3 Midwifery Study Program, Universitas Muhammadiyah Semarang, Serkia Ikhtiarsi Prakasiwi, SST MCAP, Lecturer of Midwifery Bachelor and Professional Study Program, Universitas Muhammadiyah Semarang. Honorable all the committee, thank you very much, and all participants. Alhamdulillah, all praise belong only to Allah Subhanahu wa Ta'ala, who has opened the door of His mercy. And we will always with His pleasure in every step on our life activity. Amin. Ladies and gentlemen, I'd like to welcome warmly to Universitas Muhammadiyah Semarang, especially of Midwifery Department of Faculty of Nursing and Health Science at international conference, even though via virtual. Practice, skill, and innovation in midwifery are currently developing. So this seminar is very important to increase knowledge and improve competence of midwifery. I would like to thank the speaker who will share this. Ladies and gentlemen, I hope this international conference will give benefit to all of us And also, I hope the honorable speaker will contribute their expertise and experience so as to improve our knowledge. Respectfully conveyed that in order to hold the international conference on practice on innovation in midwifery of the Midwifery Department of Faculty of Nursing and Health Science, Universitas Muhammadiyah Semarang, I, on behalf of Rector of Universitas Muhammadiyah Semarang, by reciting Bismillahirrahmanirrahim, I declare this seminar open. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you very much for nice speech. Then we are ready for the main agenda today. This conference will be guided directly by our moderator. It will be with Mrs. Agustin Rahmawati, Magister Health. Please, time is yours to start the conference.
Okay, thank you for the MC. Assalamualaikum warahmatullahi wabarakatuh. Good morning to you all. The Honorable Vice Rector 1, Dr. Budi Santosa, Magister of Science, Medicine, the Honorable Dean of Faculty of Nursing and Health Sciences, and Vice Dean 1, Vice Dean 2, University Muhammadiyah of Semarang, and respectable the Head of Midwifery Department, Mrs. Dewi Puspitaningrum and Mrs. Lia Mulyanti, Magister of Health, and the Honorable all speaker, all lecturer of Midwifery Department, and all participants of this conference. Ladies and gentlemen, my name is Agustin Rahmawati, the moderator of today's conference. I'm very pleased to see you all virtually and welcome all of you in a very special event on the first international conference on practice and innovation in midwifery, ICPIM. This conference is conducted by Midwifery Department, Faculty of Nursing and Health Sciences, and supported by International Relationship Advisor, University Muhammadiyah of Semarang. The purpose of this conference is to increase our understanding on the health policy issues in surrounding maternal and neonatal child health, especially in emergency services, not only in Indonesia, but also in overseas. Okay, we know that pregnancy and childbirth are generally times of joy for parents and families. But the health risks associated with pregnancy and childbirth are far greater in developing countries. Most maternal and neonatal deaths occur around the time of labor, delivery, and the intermediate postpartum period. So the question is, how we can prevent an emergency case during maternal and neonatal, medical legal aspect, and also how to manage reproductive health for women based on community. Happily, the question to be answered in this session to all participants. And I would like to show the speaker for this conference. This conference includes 3 speakers. For the first speaker is Prof. Dr. Zaleha Abdullah Mahdi from University Kebangsaan Malaysia that will describe about emergency services and reproductive health. For the second speaker is Dr. Fitriani Nur Damayanti, Magister of Health Law that will describe about medical legal of emergency service on maternal and neonatal. And the last speaker is Mrs. Serkia Ikhtiarsi Prakasiwi, Magister of Midwifery, that will describe about women reproductive health in community. Okay, for all participants, before we're going to the first speaker, I would like to inform you in each session is divided into 2 parts. The first part is the presentation session, and the second part we will discussion. And I want to remind you that you can submit your question at any time during a presentation through the link provided by the committee. And don't forget to vote to whom the question is addressed. And I will announce you during the session. The room chat in YouTube and Zoom will be disabled because of the room chat, only sharing about information by the committee. Ladies and gentlemen, now we're going to the first presentation session. But before we start, I would like to show the first speaker biography. Okay, could you take the screen? Okay. This is Professor Dr. Zaleha Abdullah Mahdi biography. She graduated from the National University of Malaysia in 1989. And between 1985 and 1988, she obtained her membership of the RCOG, Master in Obgyn, and MD in Newcastle, United Kingdom. Her MD research thesis was on preeclampsia, sponsored by a grant from the RCOG. She is currently professor and senior consultant, obstetrician and gynecologist at UKM Medical Center in Kuala Lumpur. Having finished her 3-year term as Dean of the UKM Faculty of Medicine in 2019. Between 2019 and 2017, she was also the director of UKM Hospital. She has published 99 articles in journal, several books and chapters in books, and more than 150 abstract and proceedings. A lot of her publication, right? Okay, and her current research interests include development of a customized Malaysian antenatal growth chart and the other. And she is an appointed member of the Malaysian Medical Council, chairperson of the Specialty Education Subcommittee for the Obstetric and Gynecology. And she is a trainer, associated editor of BMC Pregnancy and Childbirth, and Frontiers in Medicine and Frontiers in Surgery, life member of Mercy Malaysia and the Malaysian Society for Simulation in Healthcare, and current president of the Perinatal Society in Malaysia. She is a member of Taekwondo Malaysia WTF, having obtained black belt in 2011 and a regular cyclist. Okay. Could you stay with us, Prof. Dr. Zaleha?
Yes.
Assalamualaikum, Professor Dr. Zaleha.
Waalaikumsalam. Thank you very much for the kind introduction.
Okay. Okay, Prof, before you going to your presentation, please take your time for about 30 minutes for presentation. And maybe I will remain you for 5 minutes before ends. Prof. Zaleha, the floor is yours.
Thank you very much. Jazakumullahu khairan kathira. I'm very thankful to the organizing committee for allowing me this opportunity to speak to midwives in Indonesia. And for your information, I sit in the Midwifery Board of Malaysia, Lembaga Bidan Malaysia, as a representative of the Malaysian Medical Council. So midwifery is very close to my heart, and I work closely with a lot of midwives for many, many years. So I shall share my screen with you.
Hello, Prof.
Yes?
Okay.
Yeah. Can
Your
you see,
screen is show now?
can you see my screen now?
Yes.
Okay. Right. Again, Assalamualaikum warahmatullahi wabarakatuh. Bismillahirrahmanirrahim. Rabbi shrah li sadri wa yassir li amri wahlul. This is the Indonesian population statistics, just to show you the background. I'm sure you're familiar with this. And as you can see, you are a big country. You rank number 4 in the world population. And you have a huge land density, you know, almost 2 million kilometers square. What is important is your population is young. The median age in Indonesia is 29.7 years, which is quite comparable to Malaysia, and which is a reason why we can compare our two countries and share a lot of knowledge, experience, and skills. This is the population statistics for Malaysia. As you can see, we are only about 10% of your population, and we rank number 45 in the world in terms of world population. We are quite small. The median age in Malaysia is also about 30 years. So it's about the same, meaning that many women in Indonesia as well as in Malaysia are in the reproductive age, right? So which is why we will have a lot of births happening in Indonesia as well as in Malaysia. Therefore, this only means that midwifery and neonatal services are very important in these two countries. So this is what I have been asked to talk about, maternal and neonatal emergency midwifery services in Malaysia, to share with all of you the maternal health services that we have in Malaysia, and hopefully, we can benefit from each other in terms of this knowledge and experience, and also pre-pregnancy screening and management, and how this helps in preventing problems. This is our Malaysian Perinatal Care Manual. This is the 3rd edition. I was involved in the formation of the earlier edition. This is the latest one. I think this was from year 2018 or 19. It's very new. And a lot of the things that I'm going to talk about in this lecture, I take it from this Perinatal Care Manual. The objective of this Perinatal Care Manual, which we have formulated for the whole country, is to develop a comprehensive training manual and reference for general use by healthcare providers who are entrusted with the care of mothers and their newborns. And it serves as a guide on the basic knowledge and skills that are required in the care of women from pre-pregnancy until the neonatal period. And it provides management of common conditions that occur at various stages of pregnancy and postpartum. It also serves as a guide for primary healthcare providers, and I believe in Indonesia you call it the puskesmas, the pusat kesihatan masyarakat, to meet the expected standard of care in the delivery of respective services, in order to reduce morbidity and mortality among mothers and babies. In Malaysia, the health centers are called pusat-pusat kesihatan. So this is the how the manual is supposed to be handled. Okay, it is divided into 5 sections, which covers pre-pregnancy care, antenatal care, intrapartum care, postpartum care, as well as neonatal care. I believe you can actually download this from the internet if you would like to use this as sharing of information. This is just to give a little bit of vital statistics of Malaysia, which is very recent from the year 2019, last year. We have a total live birth of about 500,000, which is quite consistent every year. We have 1 baby born every minute. And the thing is, the total fertility rate for the country has been going down for many, many years. At the moment, the average number of babies born to each woman in the reproductive age group is only 1.8, just about 2. So we are just replacing ourselves. And the perinatal mortality in Malaysia is 89 per 10,000 births, or if you convert it to per 1,000, it is 8.9 per 1,000 births. Okay, whereas the maternal mortality is 23.5 maternal deaths per 100,000 live births, which is an achievement that we are very thankful for. Alhamdulillah, we have been able to reduce the death rate of women in pregnancy, childbirth, and postpartum for over the past many, many years. I will show you the graph. This is the total fertility rate. In the year 1955, for example, every childbearing woman in Malaysia produces about 6 to 7 children on average. But now the average woman produces 2 children. Okay, so we are, as I said, we're just replacing the couple, 1 wife, 1 husband, and only 2 children. You know, that's the average. Okay, of course, some women do not produce any children at all, and some produce more. So this is the average. And this is the maternal mortality rate for Malaysia for the past many years since 1933. Okay, for the past about 80 years. And as you can see here, we started off very bad. Okay, we had a maternal mortality rate of more than 1,000, which is about 1%, more than 1,000 per 100,000 women. So it is more than 1% of live births, okay, at that time. But Alhamdulillah, we have come a long way, okay. In 1957, at the time when we achieved independence, it was 280, just about below 300. And ever since then, we have made further improvements. And up until now, since the year 2000 until now, it has been below 30 per 100,000 live births. And since 1991, we have established what we call the confidential inquiry into maternal deaths, meaning that every single death in the whole country, no matter where it occurs, whether it is in a public hospital, private hospital, at home, or wherever, it is looked into. It is scrutinized in detail in order to find out what are the factors that have contributed to the death and what can we do to improve and to prevent such a death in the future. So at that time, in 1991, the maternal death was 44, and with all this confidential inquiry going on, a lot of scrutiny of the deaths, which is part of our surveillance, we have come to about half the number now of deaths. So it is actually a very important exercise, and within this exercise, we do not point fingers. There is no blame proportioning to anybody. We just want to find out how we can improve ourselves. I believe we are one of only 3 countries in the world that have a confidential inquiry into maternal deaths. The first was, of course, United Kingdom, which started off this confidential inquiry, followed by Sri Lanka and Malaysia. And it has, even in Sri Lanka, it has shown that this has got a very good impact on the maternal death rate of the country in bringing it down. And these are the main causes of maternal deaths in Malaysia over the past many years. As you can see, postpartum hemorrhage, for example, is something which usually is a plague in a developing country. And we have come to improve that from 2009 here until 2012, 2014, the role of postpartum hemorrhage has reduced a lot. And very, very importantly, what has reduced tremendously is associated medical conditions. As you can see here, this graph, it has improved from 8 up here down to about 4 to 5. Okay, in terms of costs of death per 100,000 live births. Okay, and what is this attributable to? What contributes to this? Okay, it's actually pre-pregnancy counseling. So this is also embedded in the perinatal care manual. The objectives of the pre-pregnancy counseling include conducting an initial assessment of the childbearing woman, allaying or reducing any anxiety that the woman may have with regard to her past obstetric history, which maybe have been bad, or any medical problems that she may have currently. And also providing genetic information for those women who have had abnormal babies, for example. and also determining fitness for pregnancy. This is particularly important in women who have comorbidities, for example, anemia, heart disease, especially heart disease, diabetes, and hypertension. These two are very important to control. Heart disease is important to correct before the pregnancy, if ever possible, and diabetes and hypertension are very important to control before the pregnancy. Kidney disease is also another issue. Subsequently, these women are followed up every 2 years until they get pregnant or whatever. And this is the flow chart, which you can find in the perinatal care manual of how pre-pregnancy counseling is delivered to the women. Okay, they are screened and looked at for any risk factors. If there is any risk factors, they are referred to the medical officer or family medicine specialist, and then they go into this this bubble here. Either they are referred to maternal and child health services or wellness services, premarital screening, which includes HIV in some of the states, thalassemia screening, which is quite important because many of our population have got thalassemia, and adolescent services if they are teenage mothers, if they are potential teenage mothers, that sort of thing. Okay, and some of them who have got specific problems in medicine are referred to specialist clinic, for example, the physician clinic or cardiology, nephrology, or pediatric if they have some genetic problems. So on and so forth. The history taking, investigation, and all that are done at this clinic. And health education and advice are given. This is the history of home births in Malaysia. I think it is something quite important because I do believe that in Indonesia, quite a number of women still deliver at home. In making birth safe, we have tried our best to move the women from birthing at home to birthing in hospitals. In the 1950s, for example, a total of 500 out of 100,000 mothers in the country died due to childbirth, as I've presented just now. And to tackle this problem, it was identified that one of the main problems is poorly supervised home births, by people who are not trained as skilled midwives. Some of them are traditional midwives. Therefore, it was an effort was consciously made by the government to shift the mothers from delivering at home to accepting hospital births. And as a result, by the 1970s, 30% of Malaysian mothers were delivering in hospitals. And by 2015, 99.4% of births in Malaysia were supervised by skilled birth attendants, most of which are in hospitals or alternative birthing centers. I'll talk to you about that in a while. And this is an educational piece in the Ministry of Health website that tells mothers what is important if they are considering their place of birth. Okay, what is most important is safe delivery by skilled birth attendants. And if they are considering delivering at home, they must get proper antenatal checkup, booked with a skilled health personnel with midwifery qualifications, and very importantly, registered with the Midwifery Board of Malaysia under the Ministry of Health. And it is the intention of the MOH to ensure every mother will undergo safe delivery for better quality of life for both the mother and the child. And the discussion on the preferred choice of place of delivery is started during the first visit itself, early in the antenatal care schedule. And final decision for the place of delivery is made by the 36 weeks of pregnancy, together with the health staff, the husband, and family members. If they wish to deliver at home, they are screened for risk factors. If they have risk factors, then they are advised that it is not suitable for them to deliver at home. And if they are found to be suitable to deliver at home and they don't have any risk factors, the home environment is looked into. The health staff concerned will do home visit prior to the delivery to make sure that the home environment is suitable. All right, and many of our hospitals now are husband friendly, except of course during this COVID-19 season when it is difficult to allow many visitors to hospitals. But we have been husband friendly for many years now, meaning that in many hospitals in Malaysia, the husband or one other accompanying person is allowed to accompany the woman in labor, either the husband or the mother and so on. And even when they deliver at home, this is allowed. So they feel more assured of their comfort. And this is the list of mothers who are considered as allowable or permissible to deliver at home. Okay, for example, 2nd to 5th pregnancy, not the first pregnancy, good height, reasonable age group, not the very elderly or the very young, good family support, and so on and so forth. No preterm, no post dates, and so on. And average baby size. There's a lot of things, and definitely no comorbidities. So who is eligible to conduct home births? It is only limited to skilled health personnel with midwifery specialization and registered with the Midwifery Board of Malaysia under the Ministry of Health, such as community health nurse and trained staff nurse. And if any complication occurs to the mother and baby during the process of delivery, the health staff who conducts the delivery knows that she must refer the patient as soon as possible to the nearest hospital. And what about our emergency response services? We do not have a specific line for maternal and neonatal emergencies, but we have one unified line for the whole country for any kind of emergency, whether it's emergencies concerning the police, the fire department, or the Ministry of Health. So all share the same number so that it is easy for everybody to remember. But very importantly also is that if it is a health-related emergency, while the ambulance is on its way, we have adopted the EMD protocol, Emergency Medical Dispatch Protocol. Malaysia is the first country in this region to implement this protocol in emergency services, meaning that the operator of the telephone at the other end of the line will ask you certain questions and reassure you and give you certain instructions to make sure you are well supported while waiting for the ambulance to come. This is our delivery bag for emergency deliveries, including for home births. Okay, so this is what we have in the bag. This is all the necessary equipment, plus all the sheets and syringes and all that, okay, drugs and whatnot, which are important for a safe delivery. So whenever there is an emergency call, somebody, went to labor too soon at home or something like that, or a planned home delivery, whatever, this is the bag that the midwife will carry to the home. So it is in the emergency birth area of the hospital at all times. And some hospitals go on to develop other equipment which are useful, other kits. For example, this is an eclampsia kit. So if we know that the woman has got eclampsia, this is the kit that we will bring with us, or we can use when the woman arrives at the hospital, both ways. Right, so these are the information that we impart to our pregnant women, okay, when they are considering a place of birth. We tell them that even with a planned, well-planned home birth, the transfer rate to hospital is 60%. This is the rate actually in Netherlands, one of the countries with the safest home birth in the world. Still, 60% of the women who plan a home birth gets transferred to a hospital because of emergencies. during the process of labor. And mothers are 5 times more likely to die during a home birth compared to hospital birth if there's no certified midwife in attendance. This is something that the mothers must know. And in the UK, for example, 40% of first-time mothers who have home births are transferred to hospitals. And the American College of ONG and the Australian and New Zealand College of ONG do not support home birth at all, even those attended by certified midwives. So the issue of home birth really have to be taken very, very seriously. And in America, data from over 300,000 home births shows that babies born at home have 3 times the risk of dying at birth. And half of these babies die due to asphyxiation, lack of oxygen, probably because of lack of monitoring of the heartbeat. This is the figure in Malaysia. As you can see, if you compare home birth with birth in either government or private hospitals, the risk of dying because of home birth is about 15 times that of the figure in government or private hospitals. And in Malaysia, we have an obstetric color coding system, which tells you what is the risk level of the woman. We have red, yellow, green, and white. It's almost like the traffic light, right? Okay. And red is where the woman must be referred stat to the hospital for further management. Yellow is where the woman must be referred to a hospital for specialist care, but not necessarily immediately. Green is where management is required by a medical officer in a health center, and white is where the care of the woman during pregnancy and birth can be undertaken by a community nurse or midwife. And this checklist is applied at certain periods of time during the pregnancy. The first trimester at the time of booking, then in the second trimester it is revised again, in the third trimester another revision, in fact 3 times in the third trimester, and if the woman is post dates, the 7th revision of the color code is undertaken. Okay, and a woman during pregnancy must be examined by a doctor at least twice, at the time of booking or when she's 24 weeks gestation, and again at 36 weeks, even if she is considered as low risk. And this is the discussion about where she should deliver takes into account the color coding as well, and also the suitability of the home environment. If the woman is not of code white, only code white are considered for home delivery actually, but if the woman is not code white, but she insists on delivering at home, then she is referred to the head nurse or the nurse supervisor or the medical officer or the family medicine specialist to really undertake a thorough assessment and discussion with the mother and the family, so that they are really aware of what is the risk that they are taking, and hopefully they will change their mind. And this is red code. Okay, red code is for immediate referral to the hospital, as I've mentioned. Okay, we have a checklist for that as well. As you can see, top of the list is cases like eclampsia, pre-eclampsia, hypertension in pregnancy, and so on. Okay, as well as other conditions which are of immediate urgency. Now, a very interesting concept that we have is low-risk birthing center. This is a birthing center which usually is not very far from a hospital. This usually tagged to a hospital, and the aim is to decongest the currently overcrowded obstetric facilities in hospitals. So these will be low-risk patients, okay, like code white, for example, okay. Rather than allowing them to deliver at home, we would rather they deliver in an alternative birthing center, which is called a low-risk birthing center. All right. And in this center, they will be delivered by highly skilled professionals. Like most of the time, it is a midwife, okay, in a very safe environment with easy resort to hospital facilities if need be, if there is any emergency, okay. And the data supporting the practice of this alternative birthing center is very encouraging. We find that the success of spontaneous vaginal delivery is very high, okay, more than 95%. And there is a very low risk of instrumental delivery, very low risk of cesarean section in the center, okay, and a lower episiotomy rate as well, and a very low need for neonatal admission from the center. In other words, it is very favorable for those mothers who are already screened to be low risk. And this is the flow chart of how the intrapartum care is handled during the admission of such a woman to a low-risk birthing center. Okay, they are screened again for any risk factors. If there's no risk factors, then they are entitled to be delivered in a low-risk center. It is very much like a home environment, and we empower the midwives to be the main person to deliver in these centers. I remember as a medical student, I used to like to, practice my deliveries in this center because there's not that many deliveries that go on at one time. And the midwives have got lots of time in the world to teach medical students how to conduct delivery in an appropriate manner, in a proper manner in these centers, and teach you how to stitch episiotomies and all that at leisure. There's a lot of time. Right. We have courses from time to time in obstetric emergency management, which some of these courses are tailored for midwives, as you can see here. This is conducted by our societies. This is by the ONG Society of Malaysia. We have a handbook of obstetric emergencies as well. A lot of nice pictures and infographics in there. It is available as an ebook as well, which you can buy online. And I'm part of the trainer team in this what we call the Airku team, okay, and we do visit many of the countries in Southeast Asia in order to share this knowledge with them. Whenever we go to one of the countries, we have been to Vietnam, Laos, Cambodia, even as far as India and Nepal, and also Mongolia and China, and Japan as well as Philippines, I think, with our mannequins. You know, we bring our own mannequins and set up a workshop to teach doctors as well as midwives in these countries. Indonesia is one of the countries which we have not been to yet. So we wanted to go to Aceh in February, but then the COVID started, and so we had to postpone our plans. So perhaps we can have one with Unimus as well. This is a neonatal resuscitation training program, which was started in Malaysia many, many years ago, I believe in 96. Okay, first launched in 1996, the module for training, and we have 8,272 training providers or trainers, and more than 1,000 instructors. This was actually started by UKM in collaboration with the Ministry of Health, and subsequently many other societies, universities, and so on came on board, including the Perinatal Society, which I am heading at the moment. So you can look at the information online. Right, so I think part of the theme of this wonderful conference that you have on midwifery is also what are the innovations for the future. And if I can share with you, this is something that we are working on at the moment, still very much in its infancy. You may know that in some countries, this is already a norm. Like for example, in Rwanda, I think it started in Rwanda, delivery of blood supply to remote areas of the country occurs by drone transportation. Okay, drones transport blood whenever there is an obstetric emergency in order to fight postpartum hemorrhage. So we are trying this as well in our weather here, which is totally different from what it is in Rwanda. Rwanda is a very cold country. They have highlands. They have a different topography. We in Malaysia have got a different topography, which I believe is quite similar to Indonesia. We have a lot of traffic jams, which we have to overcome whenever we send blood samples or fetch blood products, and that is a real challenge. So we thought perhaps something flying in the air would probably be a better and more efficient transport than on the ground. So if I could share with you, this video may not be so clear, but I will try. Okay, very short video. This is our maiden flight. As you can see, there is a blood delivery box there. Okay, and this is a simulated flight, not a real transport of blood, but there is a simulated pack of blood in the box that we try to transport. And we are looking at the cost effectiveness of this system. We hope to be able to pilot this in Sabah, which has got a lot of remote areas compared to the other parts of the country. But I believe even in KL, with the heavy traffic, it is also equally important. We have just published one paper on this, is in press. Okay, and the other thing that we are innovating is the Malaysian obstetric monitoring system, which we hope to launch in UKM Hospital. First and foremost, this is a web-based pregnancy record as well as smartphone-based for the mothers, so that they are empowered to know details of their antenatal care, which they can share with whoever they are bringing themselves to be under the care of. Like for example, if they, as an emergency, they end up in a different hospital or a different clinic, they can still show the doctors there, this is my pregnancy records in the form of a smartphone-based apps. And if the clinic or hospital there is also part of the network of the web-based pregnancy record, the doctor there can actually sign in and access the pregnancy records of this woman. Okay, and this will go on from pregnancy right up to the time of birth. And together with this, we hope to attach this as well. This is the customized antenatal growth chart, okay, which we have learned from the Birmingham Perinatal Institute in the UK. Hopefully this coming November, on the 24th of November, Prof. Jason Gadosi from there will be sharing with us his knowledge on this, and we will be showcasing the study that we have done in our hospital in order to validate this system. Basically, the customized antenatal growth chart take into account the mother's physiological features. For example, the height, the weight, as well as demographic features like the ethnic group, okay, in order to determine the weight of the fetus in utero, so that we have a growth chart which actually reflects our population. We believe that growth charts are different from one population to another. Indonesia and Malaysia might be able to share this because we are part and parcel of a similar ethnic group. The Malaysian, the Malays, the Chinese, for example, you know, we are part of the same kind of demographic group. So in conclusion, I would like to say that the Malaysian Perinatal Care Manual covers all aspects of pregnancy care from pre-pregnancy screening to postnatal care. It is available online to share the knowledge. If you would like to, you can download it. And the Malaysian Emergency Health Service, including maternal and perinatal emergencies, is embedded into the General National Emergency Service, which is called the MERS and MERS. Minimizing obstetric and perinatal emergencies outside hospital premises is what we consider as the key principle of our obstetric and midwifery practice, by encouraging almost 100% hospital births, taking into account that low-risk birthing centers is a much safer alternative to home birth. Okay, it is close to the hospital, but not a hospital birth. It is like a home environment, but not at home, with less medicalization of pregnancy and birth, less intervention by the doctors, okay? Mostly are carried out by midwives, and more midwifery involvement and empowerment in the management. And we have training and refresher courses in obstetric and perinatal emergencies, which we think are essential elements in midwifery practice. And in the future, perhaps emergency obstetric services will include the usage of much more technology, such as drones for medical transport and web and smartphone-based obstetric records. So with that, I thank you very much. Jazakumullah khairan kathira. Assalamualaikum warahmatullah. I open the floor for questioning.
Okay, thank you, Prof. Zaleha. Thank you for giving such information and interesting presentation for us. Okay, ladies and gentlemen, and now we come to question and answer session. I would like to have many questions from the participants, but we have already had 4 questions here for Prof. Zaleha. Prof, we have a 4 question for you.
Sure, no problem.
The first, okay. The first question comes from Mrs. Umi at Puskesmas Ringinarum Kendal. The question is, how is the antenatal care service running during the pandemic in Malaysia? Are pregnancy rates controlled during the pandemic? And how is counseling still carried out during a pandemic? And the second question from Miss Dwi Agustina from Semarang City. The question is, what are the government policy and health workers of Malaysia to reduce mortality and morbidity rate in Malaysia? Okay, that's the 2 questions first.
Right.
Maybe you can answer the question first, Prof. Zaleha.
Thank you very much for the questions. Very good. I'm glad to see questions coming in. Okay, the first question, during the COVID, yes, I think this is a global problem. We are involved as well. And initially, as you very well know, we had huge clusters with thousands of cases to start with in February to March. And Alhamdulillah, it is now under control. Now, especially in the beginning when the number of cases was very high, we had to reduce our elective cases in the hospital. We had to reduce, for example, the number of antenatal visits that the women could come for. Okay, we called our women. Now, first and foremost, in an OBGYN setup, like for example in UKM and elsewhere as well, we have certain hospitals which were designated as COVID hospitals. Our hospital was a hybrid COVID hospital, meaning that we handle normal patients as well as COVID cases as well. Some hospitals do not handle COVID at all, okay? And some hospitals almost 100% handle COVID. In our hospital, where we are a hybrid COVID hospital, our normal cases who are not COVID cases, we have to reduce the number. Okay, and I can tell you that the number of antenatal visits, gynae visits, and all that any elective clinic visits, we had to reduce them. We told our doctors to go through all the patients' records for every single clinic session and sieve out, filter out those which are not very urgent, and call the patient to tell them not to come for that particular appointment, and give them an alternative if there is anything vital that needs to be done at that visit. Most of the time it's just you know, a review visit, that kind of thing, where you know, it is okay for them not to come. All right, some of them we had a sort of video call with them, a phone call or a video call, okay, and talk to them, ask them whether they have any active problems. If they don't have any active problems and do not have any specific investigation to be carried out, then we will postpone the clinic visit for them, particularly for gynae cases. For example, like uterovaginal prolapse and asymptomatic fibroid, that kind of thing, which is not urgent. Okay, for the pregnant women, we try to distance out their visits to become further apart. Okay, so not so close together. Those who had like weekly visits, we try to make it like 2 weekly, or some maybe 3 weekly, that kind of thing. But we give them a call. Okay, and some of them, we ask them to go to the nearby clinic and have them themselves checked out in the nearby clinic. Now, in terms of deliveries as well, there was in the COVID hospitals as well as the hybrid COVID hospital like ours, the number of deliveries shrunk a lot. We used to have like 400 to 500 deliveries a month here. It came down to only about 250 during the past few months because of the movement control order. All right, and we forbid the husband from coming to accompany the wife during labor, and we limit the number of visitors as well to the wards, and even husbands to accompany their wife to the clinic. If there is no particular issue that needs to be discussed, then we ask them to wait outside the clinic, right? And the other patients, we channel them to the non-COVID hospital, okay, what we call our sister hospitals. Okay, right. The second question, I think, is about, I hope that answers the first question. So the second question is on how we reduce the number of the mortality and morbidity rates, right? Right. Yes. As I've mentioned just now, it is very important for us to have a surveillance method or a monitoring method, okay, over many years, you know, and the surveillance that we have not only is based in hospitals, but from the hospital level, it goes up to the national level, whether it is maternal mortality or perinatal mortality, okay? For perinatal mortality, it is quite impossible for us to have a confidential inquiry or detailed inquiry at the national level. It is more of data collection and also reporting at the national level. We come up with the perinatal mortality report every few years. But at the hospital level, particularly hospitals which have got trainees who want to specialize in the field, okay, we have perinatal mortality audits. It is a must. Every hospital who trains specialists must have perinatal mortality audits every month. Okay, and we look at our figures and we look at the notes of the cases, okay, and tell our trainees to present the case, and we look into it in detail. Where have we gone wrong, if we have gone wrong? Okay, or where have the patient gone wrong, and what do we need to do in order to correct the situation, in order to prevent future deaths of similar cause. Okay, and also we look into where are the majority of deaths happening in terms of location, in terms of cause of death, and why. You know, at the moment, actually, many of the deaths are what we call normally formed macerated stillbirth. macerated stillbirth of unknown reason. And from the work of Prof. Jason Gadosi in UK, they found that such cases are usually because of undetected intrauterine growth restriction or fetal growth restriction. Okay, babies who are not growing in utero but are not detected. Okay, because of uteroplacental insufficiency. This is why we have collaborated with Prof. Gadosi in coming up with our own customized antenatal growth chart, which is based on our labor room data. We had gathered about 50,000 sets of patient data, which we use in order to come up with the customized growth chart, okay, using our digitized labor room record. Now, for maternal mortality, as I mentioned just now, the confidential inquiry into maternal deaths is actually very, very useful. Okay, and every single maternal death is reported at the from the department level. We look into it and we question why this death happens. Okay, and from there it goes to the district, it goes to the state, it goes to the national level. Okay, and even at the national level, it is questioned again. Why? Where did we go wrong? Is it the system? Is it the patient? Is it the doctors? Okay, and the purpose of which is not to blame anybody, because if you want to blame anyone, nobody is going to report anything. Okay, so we actually expunge the identity of not only the patient but also the doctors, as well as which hospital or clinic the death came from. All that are deleted in the files when it comes to the national level. Okay, so in that way, people are more willing to provide the information. Okay, so that was how I think one of the important things that contributed to the decline in the deaths.
Okay. Okay, thank you, Prof. Zalia, for the answer. So during a pandemic, we have to reduce the intimate to get antenatal care services and use another way. Maybe example, phone call, video call, or alternative way to control the antenatal care, right? And the second answer, the point is in Malaysia, have a surveillance matter and the parental audit each month and always give a report to the department why the case is happens like that. Okay. And the third question for you, Prof. Zaleha, the third and the fourth question. You said that if any complication occurred to the mother and baby that may arise during the process of delivery, the health staff who conducted the delivery will refer as soon as possible to the nearest hospital. The question is, what should we do? What should we have to prepare during the refers? And the last question is, what is the training must be followed for the health workers, especially in midwifery in Malaysia, that serving an antenatal care or any emergency case happens? Okay, Prof. Zaleha.
Right. Okay. Thank you for the second question. Can I have it a little bit clearer? The last question.
The last question. Okay. The last question is, what is training must be followed for the health workers in Malaysia? Can you give an example maybe that serving an antenatal care service or the emergency case?
Okay, right. Thank you for the questions. Very relevant. Now, the third question, the third question was about emergency transfer in case there is any urgent problem that happens outside the hospital, right? Okay, now, as I've mentioned just now during my lecture, there is no specific line for emergencies, but the same line actually can be directed to the hospital as well. Okay, During the time when the ambulance is on the way, the operator at the end of the line has been trained. Actually, those operators who operate the emergency line, they undergo training from time to time, okay, in order to be able to handle the individual who is making the call, and how to direct the call and so on and so forth. Okay, so there is a set questionnaire they will ask the person at the end of the line in order to help them and to feel more reassured during the time that the ambulance is on the way. Now, in terms of the person at the site or location of the emergency, let's say, for example, if it is a midwife conducting a delivery, okay, say at home, for example, wanting to get the patient to the hospital, there are certain emergency procedures that she has to adhere to. For example, if you look at my slides, there's one checklist, okay, for the red code. Okay, this is the red code where they have to be immediately transferred to the hospital. Okay, if the woman is more than 22 weeks pregnant, then the midwife will call the emergency delivery suite or emergency line in the labor room straight away. Okay, but if the woman is less than 22 weeks pregnant, meaning that it is a miscarriage or an suspected ectopic or whatever, okay, then the line to call is the emergency department or the casualty department of the hospital. So there are two different ways, okay, or flows of the medical traffic. And for the case at hand, okay, say for example, if it is a postpartum hemorrhage, okay, we do have emergency drills that the midwife can follow. That's why it is important that the person attending, even at home, must be a trained person. Okay, so if she is a trained midwife, she will know the postpartum hemorrhage or PPH drill. Okay, or if it is an eclampsia, she will know the eclampsia drill and know exactly what to do, you know, to give magnesium sulfate and so on and so forth. Okay, and if the blood pressure is high, what to do, which drugs to give, and all that. So she will know that in detail, and will be able to handle the emergency at that point. I think the other question is related in terms of training. Yes, what we do is from time to time, whether it is at the hospital-based or clinic-based practice, okay, we have drills for our staff, okay. We carry out, say, post-PPH drill, shoulder dystocia drill, eclampsia and pre-eclampsia drill, okay, for our staff and our trainee doctors, so that if the actual situation happens, they know exactly what to do. So these are simulations. So we practice a lot of simulation, and the Airku that I mentioned just now, for example, is one of those drills that we can make use of. Okay, if we do not carry it out in our own hospital, we can send our midwives and our doctors to follow these courses, which are conducted at specific locations in the country and in specific simulation labs, okay, where they can learn all this emergency management. Same thing with the neonatal resuscitation program. We have ongoing program at regular intervals from time to time, okay, in different hospitals in the country, teaching either training fresh people, like for example, house officers and all that, and new midwives and nurses, as well as refresher courses, okay, and also training of trainers, okay. So this is what we try to bring to the countries under the AFOC, Asia Oceania Federation of ONG, okay, that is the umbrella that is supporting our work in Airku. As far as intensive courses in obstetric emergencies are concerned. So we do hope that Indonesia will be participating in this as well. Thank you.
Okay. Okay, thank you, Prof. Zaleha, for the answer. Okay, the point is drill for staff and simulation practice, a lot of simulation practice to increase their skill and follow a many course, okay, give by the staff. Okay, I think the question is enough for you, Prof. Zaleha. There are many questions, but the committee selected only 4 questions for you because the time, and we have moved along to another schedule. Okay, Prof. Zaleha, there are the point that I can underline for this session is, although most maternal and neonatal deaths occur around the time of labor, delivery, and the intermediate postpartum period, many of these causes are preventable or could be managed by skilled provider with adequate resources at the facility level. It is important to ensure midwives are able to perform not only emergency obstetric function, but also a range of essential newborn care intervention, such as a resuscitation and the other. And therefore, some midwives use the guide when advocating for the importance of linking maternal health intervention with newborn health intervention as part of the implementation of a comprehensive continuum of care for maternal and child health in humanitarian settings. Okay, Prof. Zaleha.
Thank you very much.
Thank you for joining.
Very good.
Okay, thank you for
joining.
Yeah, for this session. Hopefully we can still join another events.
Inshallah.
Okay.
Inshallah.
Yeah, inshallah. Okay, thank you again, Prof. Zaleha. Really great presentation from you. Okay, wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. I will leave the meeting now. Thank you.
Okay, thank you, Prof. Zaleha. Yeah. Okay, and ladies and gentlemen, for the next agenda is a panel session for the second and the third speaker. Please welcome Dr. Fitriani Nur Damayanti, Magister of Health Law, and Mrs. Serkia Ikstiarsi Prakasiwi, Magister of Midwifery. Please have your seat. And I will to remind all of you participants, you can submit your question at any time during a presentation through the link provided by the committee. And don't forget to vote to whom the question is addressed. Okay, now the panel session. We present Dr. Fitriani Nur Damayanti, Magister of Health, to be first speaker. And the next speaker is Mrs. Serkia Ikstiarsi Prakasiwi, Magister of Midwifery. For the first turn, Dr. Fitriani Nur Damayanti, Magister of Health Law, will share about medical legal of emergency service on maternal and neonatal. But before we start, I would like to show Dr. Fitriani Nur Damayanti, Magister of Health Law CV. Could you take the show, the Dr. Fitri CV to the screen? Yes, Dr. Fitri CV. Okay. Okay, maybe we should going to the topic, the main topic. Dr. Fitri CV maybe will show after the presentation. Okay, Dr. Fitri, please take your time for about 30 minutes, and I will remind you for 5 minutes before ends. Dr. Fitri, the floor is yours.
Okay, thank you very much, Mrs. Agustin. The Honorable Prof. Zaleha Abdullah Mahdi from University Kebangsaan Malaysia, the Honorable Head of Midwifery Department, Mrs. Dewi Puspitaningrum, Magister of Health, and Mrs. Lia Mulyanti, Magister of Health, the Honorable all Lecturer of Midwifery Department, and all participants of this conference. Assalamualaikum warahmatullahi wabarakatuh. Thank you for the time you have given me. I will explain the topic in this conference with the title Medical Legal of Emergency Service on Maternal Neonatal. Slide. Medical Legal of Emergency Service on Maternal Neonatal. Slide. Law of the Republic Indonesia, number 4 of 2019 about midwifery. Slide. A midwife is a woman who has completed an midwifery education program both domestically and abroad, which is legally recognized by the central government and has met the requirement to practice midwifery. Midwifery service is a form of professional service that is an integral part of the health service system provided by midwife independently, collaboratively, and or by referral. Slide. Law of the Republic Indonesia number 4 of 2019 about midwifery. Midwifery practice is a service provision activity by midwife in the form of midwifery care. Midwifery care is a series of activities based on the decision-making process and actions taken by midwife in accordance with the authority and scope of practice based on midwifery knowledge and tips. Ethical clinical decisions are very important and are expected to achieve optimal obstetric care, so it requires professional of midwife in providing midwife service. Professional of midwife, they who are disciplined, hold to ethical standards, and uphold also are accepted by the public, having special knowledge and skill with an organized experience in education and training, then ready to share it to the others. Midwife professional indicators hold to the philosophy, professional ethics, and legal aspect to be responsible, do appropriate collaboration and referrals, improve their education, competent, and provide advocacy. The professional of Indonesian midwife is regulated in laws such as Law number 13(6) of 2009 about health, Law number 36 of 2014 about health workers, Law number 4 of 2019 about midwifery, and Minister of Health Degree of the Republic Indonesia number 0107 2019 about midwifery professional standard. The maternal and neonatal mortality rate cannot be separated from the increased issues by about the health policy. One of the indicators that can be used to measure the attainment of public health is the maternal and neonatal mortality rate. Midwives have professional responsibilities to them as health professionals. Midwives must understand the practice of midwifery with a regulated system. Midwives should be aware that they work based on statutory and professional regulation to carry out midwifery service practice. This is maternal mortality rates. Indonesian from the Asian country maternal mortality rates of Indonesia in 2015, 305 in 100,000 live birth. Indonesian maternal mortality higher than Cambodia, Malaysia, and Vietnam. Next. Maternal mortality rates, search levels and trends in child mortality report from UNICEF, WHO, World Bank, United Nations. About every day, 830 mothers in the world. In Indonesia, 38 mothers based on mortality rate, 305 died as a result. 94% of maternal deaths occur in low and lower middle income countries. Young adolescents a higher risk of complication and death as a result of pregnancy than other women. And then this is neonatal mortality rates from Indonesia. 47% was neonatal mortality. The surge from the level and trend in child mortality from UNICEF, WHO, World Bank, United Nations. Maternal and neonatal mortality rates due to emergency cases, the cause of maternal mortality rates, such as severe bleeding, mostly bleeding after childbirth, infection, usually after childbirth, high blood pressure during pregnancy, preeclampsia and eclampsia, complication from delivery, unsafe abortion. Cause of neonatal mortality rates, namely respiratory disorders, low birth weight and premature, seizures, tetanus neonatorum, and infection. Emergencies can be divided as serious and dangerous situations that occur suddenly and unexpectedly and require immediate action to save life. Maternal emergency are life-threatening health conditions that occur during pregnancy, postpartum, or birth. And then neonatal emergency are situations that require proper evaluation and management of the critical ill newborn and require knowledge in recognition the psychological change and life-threatening pathology condition that might arise at any time. Next. The authority of midwife in law number 4, 2019, one, maternal health service, infant health service, women's reproductive health service and family planning program, implementation of tax based on delegation and authority, performing tax under certain circumstances. The authority of midwives is providing emergency service to mother and children based on law number 4 of 2019. There, maternal service, perform emergency first aid for pregnant women, childbirth, postpartum, and referrals. Neonatal health service, providing first aid to newborns, followed by referral. The principle of emergency management, 1, calling for help, 2, use personal protective equipment,
3. Priorities who respond. 4. Helping to use PPA. 5. Availability of emergency kit. 6. Use effective communication. 7. Pathway application. 8. Allay to woman's fear. And 9. Plan to the transfer. Next. The role of midwife in handling emergency case. You can introduce 2 emergency conditions immediately. Client stabilization for the mother with oxygen, fluid therapy, and medicamentous. Prepare facilities in the birthing room. Have a clinical skill. Evidence-based essential intervention to reduce maternal and neonatal mortality rates. For the pregnancy, vital sign examination, immunization, tetanus, preventive and management of malaria, HIV screening. For the childbirth, giving prophylactic, uterotonic to prevent bleeding, postpartum hemorrhagic management with masses, and uterotonica. Active management stage 3. For the postpartum, treat anemia, detection and management of postpartum infection. For the newborn baby, warm the baby immediately, early initiation of breastfeeding, hygiene, for care for the umbilical cord and skin, resuscitation, and kangaroo methods. Okay. Midwife in implementation neonatal maternal emergency service must be in accordance with their competence. If there are complications and emergency cases, a midwife is obliged to carry out stabilization before making a referral, of course, in accordance with the competence of the midwife, so that mothers and babies receive optimal service. If it's not in accordance with the competence and authority of the midwife, there will be dirty declaration of the dirty damage direct case relationship. The main things that the profession must do is seek negotiation and mediation when there is a lawsuit or suit from the client or the patient. Okay, the conclusion about medical legal service neonatal, maternal neonatal, about medical legal in maternal neonatal emergency is service in emergency case carried out by midwife based on regulation in accordance with their authority and competence. It is necessary to have a medical legal aspect by paying attention to the rights and obligation between patient and medical personnel or midwife in order to minimize and avoid demands from patient and medical dispute cases. Okay, thank you very much. Make dream come true. You can very big dream. Thank you very much for the opportunity. I will return it to the moderator, Mrs. Agustin.
Okay, thank you very much, Dr. Fitri, for the nice presentation. Before we going to discuss, I would like to show Dr. Fitri's CV. Could you take on the screen, Dr. Fitri's CV? Okay. Before we going to discuss. Okay. Here, Dr. Fitri's CV. The name, Dr. Fitriani Nur Damayanti, Magister of Health Law. The date of birth, 18 May 1989. And the marital status, married. Former educational background, between 1994 till 2006, she graduated from elementary school till senior high school. And her undergraduate program for Diploma 3 of Midwifery between 2006 till 2009, and her Diploma 4 of Midwifery between 2009 till 2010, and her postgraduate program in Master of Health Law between 2010 till 2012, and her postgraduate program in Doctor of Health Law between 2016 till 2019. And then about her association. She is in Indonesia Midwife Association for Central Java Province as a legal section between 2018 till present. And she is a member in Forum Journal Perguruan Tinggi Muhammadiyah University Journal Forum between 2018 till present. And then her editor and reviewer experience. Dr. Fitri as a chief editor in a Journal of Midwifery, University Muhammadiyah of Semarang between 2012 till present, and as a reviewer in a Journal Research Midwifery, Politeknik Harapan Bersama Tegal, and Journal Hukum Replik Universitas Muhammadiyah Tangerang between 2019 till present. And then there are many publications of her that we can see in the website are ARCID ID, Scopus ID, Sinta ID, and the Google Scholar. And her intellectual property rights. She has 2 intellectual property rights in 2019, like a textbook, 2 textbook Perlindungan Hukum Profesi Bidan and the Profesionalisme Bidan Berbasis Transcendental. Okay, I think enough the CV of Dr. Fitri. Now we're going to discuss. Okay, before we're going to discuss, we move to the last speaker first. Okay, sorry. We move to the last speaker in this session. Okay, hello Mrs. Serkia, are you ready?
Ready.
Okay, Mrs. Serkia will talk about women reproductive health service in community. But before we start, let me introduce Mrs. Serkia CV. Okay, Mrs. Serkia CV. Yeah. The name Mrs. Serkia Ikhtiarsi Prakasiwi, Magister of Midwifery. And her educational background between 1996 till 2007, she graduated from elementary school to senior high school. And her bachelor degrees between 2007 till 2012. And her master of degree in Universitas Aisyah Yogyakarta, especially in Master of Midwifery between 2015 till 2017. Her work experience, we can see, between 2012 till present, she's a lecturer in Stikes Muhammadiyah Klaten and a lecturer of undergraduate program and professional program of midwifery, University Muhammadiyah of Semarang, till 2017, between 2017 till now. Her research, there are many research between 2015 till 2020. And her last research is the effectiveness of stretching procedure for dressing this manor pain in Sleman, Yogyakarta region. And her community service, the last community service in 2020, as a health education about early detection of toddler growth for parents in Posyandu Melati Ledok of Salatiga City. And her seminar and workshop, many seminar and workshop between 2017 till 2020. The last is strengthening the intention of journal manager. Okay, I think enough. Ms. Serkia Ikhtiarsi Prakasiwi CV. Now, Mrs. Serkia, same with Dr. Fitri, please take your time for about 30 minutes. And I will remind you before 5 minutes before ends. Mrs. Serkia, the floor is yours.
Yes, thank you, Mrs. Agustin. First, the honorable for all speakers, the honorable head of Midwifery Department, Mrs. Dewi Puspitaningrum, Magister of Health, and Mrs. Lia Mulyanti, Magister of Health, and the honorable all lecturer of Midwifery Department and all participants of this conference. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. I hope everyone in good condition. As we know, we are in pandemic COVID-19 situation. Before my presentation, I will introduce myself. My name is Serkia Ikhtiarsi Prakasiwi. You can call me Serki or Serkia. I live in Central Java, Semarang City, Indonesia. And right now, I'm a lecturer concentrate in midwifery study major Unimus. Okay, today I will present about women's reproductive health services in the community. Let's get started. Next. Yeah. Contents of women's reproductive health services in the community have a 4 parts. First is reproductive health. Second is women's reproductive health services in the community. Third is the role of midwife and reproductive health services in community. And fourth is innovation on reproductive health services. Next. Yeah. What is health reproductive? Health reproductive is a healthy condition, physically, mentally, and socially as a whole unit. It is not limited only free from diseases or disabilities that relate to the reproductive system, reproductive function, and reproductive process of man and woman. So the reproductive health is not only for a woman, but also for a man too. And then target of health reproductive is 4 parts. First is man target, such as man and woman in childbearing age, unmarried adolescents, and then risk group, such as sex workers, people belonging to the unprivileged families. And the third is adolescents reproductive health components, such as sexuality, being at a risk, or suffering from HIV/AIDS, being at a risk, and drug users. And the last is intermediate target, health workers, like specialists, general practitioners, midwives, nurses, community-based service providers. Next. Yeah. This is a reproductive right. There are 4 parts. First is living a reproductive life and sexual life that is healthy, safe, and free from conception and or violence with a legal partner. And then having rights to determine when and how often to do healthy reproduction and does not contradict with religious norms. And then determining their reproductive life and free from discrimination, conception, and or violence that respect to the God values that do not degrading human dignity in accordance with religious norms. And the last, getting correct and accountable information, education, and counseling regarding reproductive health. Next. Yeah, this is a life cycle. Women have a life cycle in her life. There are 5 life cycles. First is pregnant woman and conception. Second is babies and children. Third is adolescence. Fourth is childbearing age. And the last is elderly. If the woman have a not good condition, is impact to the future of the woman. For example, if pregnant women with anemia are at high risk of bleeding during childbirth, and babies who are born and are at risk of experience low birth weight. And then in the fase of babies and children, this low birth weight will grow up to be a child who has stunting and has a poor health status. And he also has a further impact on his health in adulthood and old age. And then the impact in adolescents girls with anemia who do not receive intervention will experience anemia when they become pregnant in the future, which will mostly affect their maternal health. Next. Yeah. Slide 7 until 10 is taken from Dr. Erna Mulati, MSc CMFM, Director of Kesga, Dirjen Kesmas at 18 June 2020. Next. Yeah. This is about the reproductive health and PP number 61, 2040. And this is a scope of the reproductive health ICPD Cairo. The part of reproductive health is many parts. First is reproductive health for elderly, and the health for mother and children, family planning, abortion, health reproductive for teenagers, sexual health, violent sexual, IMS and HIV/AIDS, infertility and early detection for cancer cervix. Next. Yeah, this is about the problem of health mother and children. We can see this number of death of mother. We can see the data and we see we have a target on 2024 is 183, and then the number of death of baby, the target in the 2024 is 16, and the prevalency stunting, we have a target on 2024 is 14, and the last total fertility rate is the target for 2024 is 2.1. Next. Yeah, this is a other problem for reproductive health. There are for nutrition, fertility, violence, wedding, abortion, mental, and infection and not infection disease. We can see the data. And the next. Yeah. This is a reproductive health services. What is reproductive health services? Is an activity and or a series of health activities that are promotive, preventive, curative, and rehabilitative in a nature, which contribute to reproductive health. Yeah. Reproductive women's health services in the community is 3 parts. One is women's reproductive health services in the community can be provided by all trained health personnel and according to their capacities, such as a doctor, midwives, and nurses. And then apart from health professionals, support parties can also provide healthcare services in the community, such as trained carers. And then last, health workers can collaborate with other sectors, such as community leaders, government, religious leaders, NGOs, local community groups. Yeah. In the pandemic COVID-19, health officers need to pay attention to several things of services during the COVID-19 pandemic. Next. First is encourage all push to delay pregnancy by continuing to use contraception in the COVID-19 pandemic situation by increasing the delivery of information to the public. And then health workers must use PPE with a level that is tailored to services provided and ensure that clients who come use masks and make a prior appointment. And then the cadres in assisting the service are also expected to make preventive efforts by always using masks and immediately washing their hands using soap and running water or hand sanitizer after meeting clients. Yeah. What a role of midwives in reproductive health services in the community? Yeah, next. Yeah. First is the activation of reproduction health coordination. There are reproductive health coordination, preparation of vigilant team of development for health reproductive, direct coordination by the center with intense coaching, advocacy for sustainability function, and last coordination and preparedness. And then the prevention and management of gender-based violence is reproductive health education, including family planning, provide information and services on sexual violence management, provide medical services, initial psychological support for rape survivors, and health referral mechanism. And then the prevention of sexual transmitted disease and HIV is providing information on the availability of IRV services, implementing standard precautions, ensuring the availability of contraception. And then the adolescents inclusion and youth engagement is referral mechanism information, education of health reproductive for adolescents. Yeah. Preventing increased maternal and neonatal morbidity and mortality is providing delivery assistance and maternal and neonatal emergency services, knowing the referral mechanism, adopting standard precaution, and the prevention of unwanted pregnancy and family planning program is providing family planning services, facilitating community involvement, and report the availability of alcohol. Yeah. So, what is innovation in reproductive health services? Next. Yeah. Innovation is the introduction and application of new ideas, processes, products, and procedures to the implementing units which are designed to give benefit to individuals, groups, organizations, and society at large. Healthcare is an enormous affair with the most space for innovation. This is because the challenges in healthcare are indeed much more complex. Complexity is what generates various ideas. In health matters, almost all problems faced are priorities that are difficult to postpone solving. Problems in health matters, if ignored, will create new problems. For the reason, innovation is needed in health services. This is an innovation component. There are 4 parts. First is relative advantages. This is an innovation must have advantages and more value than previous innovation. And then compatibility. Innovation must have the character that are in accordance with previous innovation. And complexity, innovation having more complexity than before. And reliability, innovation must tested and proven to have more advantages. This is a literature review of innovation reproductive health services. There are 3 journals. First is about personalized medicine reproductive health service. The research is Jamhor Marta Disubrata at 2019. The research design is literature review. The result is developing clinic medicine, also followed by evidence-based medicine and genome medicine, otherwise personalized medicine, developing medical practice individuality to be better. And then the second journal is about implementation of reproductive life planning RLP in primary healthcare supported by an evidence-based website. The researchers is Anderson and Tyden at the 2019. The research design is a cross-sectional study. The population and sample is 73 midwives in primary health care. And the result is the RLP was well implemented among the respondents, and the majority considered the website to be a useful tool. Long-term studies are needed to further elucidate the effect of the RLP on change in health behavior and pregnancy outcomes. And the last journal is about audiovisual media to improve sexual reproduction health knowledge among adolescents. The researchers is Sulistiawati et al. At 2020, the research design is experimental study design, and the population and sample is 153 students in the first until third grade of junior high school. And the result is the effect of the intervention was assessed to the difference between pre and post intervention by using the Wilcoxon test. The main score of the respondent pre and post intervention was significantly increasing. The audiovisual increased the knowledge of the adolescents regarding sexual reproductive health. Yeah, this is a pic of women's reproductive health services activities in community in Midwifery Department of the Unimus. There are EVATES in Bandungan, Village Semarang, Sadari Counseling on women reproductive health, family planning, and then next, yeah, health education about balanced nutrition, IBM PMSEU group in Semarang City, counseling on reproductive health in Jati Semarang, yeah, and counseling about family planning in Gemah Semarang, community service with Kedris in Ketilang Semarang, and the community service in Waleri Kendal. Yeah, thank you. This is my presentation. The time, I'm back to moderator.
Okay, thank you, Mrs. Sergio, for the presentation. Okay, ladies and gentlemen, this time is time to be discussion to get the clear information about that presentation. I have already about 4 questions again. And the first question comes from Mrs. Siti Marfuah from Jepara. The question is, why midwives must be implementing neonatal maternal emergency service must be in accordance with their competence. And the second question from Mrs. Dwi Agustina from Puskesmas Kalongan Semarang City. The question is, why medical legal is very important in maternal neonatal emergencies? I think this question is still going to Dr. Fitri. And the third question is from Mrs. Tri Pambudi from Midwife Practice Clinic in Solo City. The question is about the cadres. The health cadres who participate in reproductive health service must be trained And the last question from Mrs. Prita from Depok City. Okay, the question is, how the midwife collaborates with cross-sectional? For the 3 and 4th question, I think it's still going to Mrs. Serkia, right? Okay, who is the first answer? Maybe Dr. Fitri will answer the question. Okay, please, Dr. Fitri.
Okay. Thank you very much for the opportunity for the questions given. This is a very good questions. The question, why midwife must implementing neonatal maternal emergency service must be in accordance with their competence. Because if there are complications and emergency cases, a midwife is obligated to carry out stabilization before making a referral, of course, in accordance with the competence of the midwife, so that mothers and babies receive optimal service. If it's not in accordance with the competence and authority of the midwife, there will be the relaxation of the duty, damage direct case and relationship. Okay, question 2.
Okay, from Miss Dwi Agustina from Puskesmas Kalongan, Semarang City, Dr. Fitri.
Okay,
Okay, about medical legal.
About medical legal,
yes.
Okay, thank you for the question. I'm very interested in this question about why medical legal very important in maternal neonatal emergencies. I think because medical legal aspect, by paying attention to the rights and obligations between patient and medical personnel, this is a midwife, in order to minimize and avoid demands from patient and medical dispute case. Okay, thank you very much. To question for me.
Okay,
Mrs.
that's enough
Agustin.
for the answer about the question, Dr.
Yeah.
Fitri.
Yes.
Okay.
Okay, the question.
I can underline your answer. The first is about the implementing neonatal maternal emergency service, and it's really important for a midwife to carry out stabilization before making a referral. Right, Dr. Fitri? And accordance with their competence and authority of the midwife, there will be jati, dereliction of the jati, direct case relationship, right? And the second, about the medical legal, is very important because the medical is one of aspect. Yeah, one aspect of the rights and the obligation.
Obligation.
Yes, obligation between a patient and a medical
personnel. And
okay.
this is a midwife.
Especially a midwife.
Yes, midwife.
Okay. Okay, thank you, Dr. Fitri, for the answer. And the next, maybe Mrs. Serkia will be answer the third and the last question from the audience. Okay.
Yes, Mrs. Agustin Ramawati, thank you. First question is whether health cadres, about cadres who participate in reproductive health services must be trained. Yeah, of course, cadres must be trained because it has become a standard that must implement it. And the second question, is how the midwife collaborates with cross-sectoral. Yeah, how? Because by approaching them, after that, together provide services to the community.
Okay.
That is.
Oh, that's enough?
Yeah, enough.
Okay, for the third question about the cadres. Cadre must be trained. You said that, yes, cadres must be trained with the standard. Maybe can you explain more? What is the train? who give to the cadres in a reproductive health service? Can you explain more? An example maybe?
Yeah, about the health of mother and baby, family planning for the elderly, and for the reproductive health for teenagers.
Okay, maybe give us some information. Okay, and the last question about the midwife collaborates with cross-sectional. It's really neat. A midwife should be collaborate with the other
Cross-sectoral.
yes. Cross-sectional.
Cross-sectoral.
Yeah, cross-sectoral. Okay,
Yes.
so this important too. For the midwife, have to collaborate with cross-sectoral.
Yes.
Okay, cross-sectoral. What can you describe? What is the cross-sectoral?
Yeah, the cross-sectoral is the community leaders, governments, religious leaders, NGOs.
Okay. Okay, thank you for the answer, Mrs. Serkia. Really the great answer from Dr. Fitri and Mrs. Serkia. Okay, I think the questions are enough for us now. And all participants, we would like to present. I will remain. Don't forget to fill in the evaluation link in YouTube or Zoom media by the committee. And ladies and gentlemen, we finally come to the end part of this conference. Before I close the conference, I would like to take the conclusion from what the speakers have presented. Reproductive health is almost important in any society. It governs the health and hygiene of the newborn and the mother. And also, emergency is any medical problem that could cause death or permanent injury if not treated quickly, and the medical legal is something that involves both medical and legal aspects. So, for well-being of a society, maintenance of its spot, maintenance of reproductive health, and keep a medical legal aspect is very important to keep a health service from health workers, especially for the midwives. And midwife in implementing maternal neonatal service must be in accordance with their authority and their competence. Okay, ladies and gentlemen, I'd like to thank so much to the speakers for informative, interesting presentation, and to the participants for very active participation. Hopefully, the conference will be beneficial for everybody. Amen. Okay. Please forgive for all my mistake, maybe happens. Please give applause for the speaker and for you all. And I will back the time to the MC. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Okay, thank you to our speakers today for sharing the material. We will continue to the next agenda. It is introduction to midwifery journals. It will be delivered by our speakers too. Here there are Dr. Fitri and Mrs. Serkia. Please, time is yours.
Okay. Thank you for the opportunity given. I will introduce the Midwifery Journal of the Muhammadiyah University of Semarang. Okay. Midwifery Journal from University Muhammadiyah of Semarang. Slide. Next slide. Okay. Midwifery Journal. The name is a Jurnal Kebidanan. Midwifery Journal is an electronic journal published by Midwifery Department, Faculty of Nursing and Health Science, University Muhammadiyah of Semarang. From Indonesia. Midwifery Journal was firstly published in Augustus 2012. This journal is published twice a year, such as in February and August. This journal Kucinta Level 3 Certified Midwifery Journal. Okay, next. Focus and scope, midwifery journal, pregnancy, maternity, childbirth, neonatus, family planning, reproduction health, adolescent health, elderly health, maternal health, child health. Next. Okay, the journal website is journal.onimus.ac.id, and you can send message via email with the address jurnalkebidanan@onimus.ac.id. Okay, I hope you can like and share from the website Midwifery Journal from University of Muhammadiyah Semarang. Okay, please open the website Jurnal Kebidanan. Website. I want to introduce the website from Midwifery Journal. You can see how to submit as an author. You can see a website Midwifery Journal. Okay, this is a Midwifery Journal website, journal.onimus.ac.id. You can see how to submit as an author, and if you are interested, you can become part of the editorial team or a reviewer with appropriate educational background. You can become an editorial team or the peer review this journal. I hope you can be a part of our journal. Okay, I think enough from the introduce Midwifery Journal. Thank you very much for your attention. Okay, when I back to the MC. Oh, okay. We continue to Mrs. Sergia. I'm sorry.
Yeah, thank you, Mrs. Dr. Fitriani. Yeah. I will explain about the Jurnal Pengabdian Masyarakat Kebidanan. We have a Jurnal Pengabdian Masyarakat Kebidanan. Yeah. Jurnal Pengabdian Masyarakat Kebidanan Fikes Unimus. Next. Jurnal Pengabdian Masyarakat Kebidanan provides media for those who want to publish the scientific articles from the result of community services, research, or innovation in the field of midwifery, maternal health, and child. And Jurnal Pengabdian Masyarakat Kebidanan publish its issues twice a year, every January and August. At least 10 articles will be published in each issues. Next. What the focus and scope? There are pregnancy, maternity, children, neonates, infants, toddlers, and preschool children, maternal health, family planning, reproduction health, adolescent health, elderly health, and children's health. This is our email and jpkkebidanan@unimus.ac.id, and this is the website and link for the journal. We can see, and we can visit the website. Next. Yeah, thank you. If you do any question, you can find me at cpkkebidanan@unimus.ac.id. We can see the website. Yeah, this is our journal. You can visit this website of the journal. If you have an article, you can submit at the Jurnal Pengabdian Masyarakat Kebidanan. Okay, thank you. I think it's enough. Time back to MC.
Okay, Alhamdulillah, finally we are in the end of the conference. So let's say Alhamdulillah together. Alhamdulillahirrabbilalamin. Thank you very much for this nice discussion. Hopefully this pandemic will be end soon and we can continue to do our daily activity normally again. See you on the next conference, inshallah. Sorry for the inconvenience here. Wassalamualaikum warahmatullahi wabarakatuh.